Really want to talk about reimagining cancer research and its implementation across Europe, but I'm also going to touch on a number of things, including work that Norway is involved in, and delighted to meet friends and colleagues from the Norwegian Cancer Society who are involved in the International Cancer Benchmarking Partnership that I'll talk about in a while. But what I really want to do is set a scene, and unfortunately the scene that I'm setting is not necessarily a great one in Europe, but I think we can do, by working together, we can really achieve a lot. I would suggest that Europe is facing a cancer crisis unless we act now. We have seen the impact of the COVID pandemic and particularly national lockdowns, and I'll show you some European data in relation to that. The Russian invasion of Ukraine has also had unexpected step in relation to cancer, particularly in relation to clinical trials, and then the global economic downturn as a result of that. One of the things we did when we set up the Lancet Oncology European Groundshot was really to look at challenging what we're doing at the moment and how we might do it better. And one of the things that Ketil will be delighted to hear is we use data as the driver. I would go as far as to say that, too often opinion, which to me is the lowest form of evidence, so opinion is not evidence-based, it's simply opinion, and no matter how expert, really has trumped data in the genesis and implementation of cancer research policies, and we really wanted to change that. So if you remember one thing from my talk, data eat opinion for lunch. So really looking at ways in which we could reimagine cancer research and implementation, and also how we could look at those realities, addressing them on the ground. Just going to go back before I go into more of the detail in relation to the Groundshot itself, to about 3 or 4 years ago, where we set up in the UK a health data research hub for cancer, which is called DataCan, and really is bringing together all different disciplines to work together in relation to the use of data and its use in relation to driving cancer research, but also cancer policy. Our idea was to improve access to the use of data, to enhance the quality of that data, to ensure fair principles in the collection of that data, but something that's really important and something that we focused on a lot, to ensure fair value in the use of data. And that fair value needs to be first to the patient, secondly to the health system, third to the researcher, but also fourth to industry. And if we don't get that balance right in relation to fair value, then we won't succeed. So it's really important that we look at that in a lot of detail. For me, COVID-19 was personal. My uncle died of a COVID-related illness on the 29th of March 2020. And one of my colleagues there on the left, Edward Vidoliak, who's an oncologist from Croatia, while he was reaching out to me to sympathize with me on my loss, said this very startling statement about what was happening in his home country of Croatia. He said, people are starting to fear a COVID diagnosis more than a cancer diagnosis. And myself and my good friend Richard Sullivan thought about that and thought anecdotally we'd sort of heard sort of rumours of that in the UK as well, but there was no hard data, no evidence to either support or refute what Edward was saying. So what we did was we looked at rapidly accessing real-time data from hospital trusts right across the United Kingdom to look to see, well, what was the impact? And often the analysis that you do that is simple is actually better than more complex analysis. So we didn't try and look at 50 or 100 or 150 different parameters to try and see whether this was true or not. We just looked at 2. We looked to see what was the impact in relation to what we call 2-week wait, what most people would call red flag referrals. So referrals with somebody with a suspicion of cancer and to see whether they had cancer or not. And the second was to look at access to chemotherapy as a marker, if you like, of the therapeutic pathway. So one measure in the diagnostic pathway, one measure in the therapeutic pathway of the impact of COVID-19, but more particularly national lockdowns. And what we saw really surprised us. 7 out of 10 people with suspicion of cancer not going to their GP or not getting referred on to cancer specialist services. 4 out of 10 cancer patients not getting access to their chemotherapy. We were so shocked by this data that we immediately wrote to the 4 chief medical officers in the 4 nations of the United Kingdom and highlighted it with the National Cancer Director, because it was really quite startling what had happened. And here's just an example of another study that we did, again to show the impact here on endoscopy as a procedure that we use in relation to diagnosing a lot of GI cancers. And you can see there the impact, 91% drop in endoscopies from April 2019 to April 2020. We then looked at this at the European level, working with the European Cancer Organization. Not going to show you all the data, but I think these 2 again stand out. 100 million cancer screening tests not performed in Europe as a result of the pandemic. 1 million cancer patient diagnoses may have been missed. So this really sort of, if you like, set the scene in terms of where we were in relation to cancer research and its implementation in Europe. And we set out a vision, and it's quite an ambitious vision, 70-35. That is 70% long-term survival by 2035 in all countries in Europe. And this is the first recommendation of our European Cancer Groundshot. But we don't believe it's shooting at the moon. We really believe that it's firmly grounded in reality and the challenges that we face, and that's why we called it the European Groundshot. The other thing that came out of the large amount of analysis that we did over 3 years involving 50 experts, involving a whole host of different data analyses, was that patients who are treated in research-active hospitals have better outcomes than those who are not. So research is not a luxury. It's not an add-on. It's something that would be nice to do of those universities in their ivory towers. This is an essential and an integral part of modern European cancer care. So if there's a second message that you get from this talk, it's research actually delivers better care for patients. We then looked to see, well, what were some of the data that we gathered and what were their implications and what were the recommendations that we've made to change that? The first was disappointing, but probably not surprising. If we look at the original European Union, the countries of Western Europe and the European Union, a doubling of cancer research in the period that we looked at it. But if we looked at the EU13, so the accession states from Eastern Europe that came into the European Union, you can see there, except for Poland, all the other countries, little or no progress, so essentially stagnation. And that means that we really need to look at ways in which we can do capacity building, directed funding, twinning, etc., so that no matter where you live, you can benefit equally from the advances in cancer research. The second thing was we looked at the comparison between Europe and the United States, two powerhouses of cancer research, and we saw a significant mismatch. And this is just in public cancer research funding. So this is not private, this is just public, and it's all of Europe compared with the US. Europe spends approximately €26 per head on cancer research, we found. The US spends nearly 10 times that much. So one of the recommendations was we really need to up our game in relation to supporting cancer research in Europe. The other thing we looked at was the research portfolio, and we felt that based on the data that we generated, we needed a much more comprehensive research portfolio. And that needed to emphasize not only basic research, not only precision medicine, but also health policy, systems research, and particularly implementation science. Just to give you an example, but I could give you a number more. If we look like a disease like breast cancer, like lung cancer, what we find is it is 21% of the disease burden in Europe for cancer, but it's 4% of the research effort and also 4% of the research funding. Does that make any sense? Not to me. It doesn't make any sense at all. So we need to really look in terms of using data intelligence rather than opinion to understand what we should invest in and how we should invest. I could give you similar data in relation to pancreatic cancer, in relation to colorectal cancer. This is really interesting, and it's really interesting and something that Norway is actually doing very well in. One of the things we looked at was gender equality in cancer research leadership. And we found, and this was work that was done on the Commission, and then further we went into this in more detail in a paper that's just been published in the European Journal of Cancer. What we looked at was senior leadership in relation to male or female in Europe based on publications. And what we found really disappointed us. Only 5 of 31 countries had actually reached our 45% target in relation to gender, in relation to female versus male cancer research leadership. We can see that a further 5, including Norway, sit within the 40 to 45 percentile, so are doing pretty well. But if you look at 15 European countries, less than 40% female cancer researchers in leadership positions. And for 6 of those countries, including Germany, including Switzerland, who are 2 powerhouses of cancer research, it's really disappointing, below 30%. So we feel we can learn from the Central and Eastern European countries and the Nordic countries, including Norway, which have shown the way forward in relation to female cancer research leadership. The other thing we need to look at is diversifying our portfolio in relation to where we fund in relation to particular areas of research, so prevention and screening. Prevention, 4% is what we expend in relation to cancer research and prevention in Europe. Again, a paltry figure when we consider the potential advantages. And I was delighted to see a reference by the Secretary General to screening, to prevention research in relation to the Norwegian Cancer Plan. And the other thing is working together does make sense. So again, we've shown, again by analysis, the comprehensive cancer centre model. So one of the reasons why we're here today, and again, obviously Norway has a very effective comprehensive cancer centre, leads to better research and innovation that leads to better care. One of the things that Europe is great at is breakthrough. One of the things it's not so good at is follow through. So one of the things we need to look at being ways in which we can leverage the infrastructure that we have created and continue to create, but make it more than the sum of our parts. But comprehensive cancer centres and comprehensive cancer infrastructure does make sense. The other thing, if we look at modalities of both treatment and modalities in relation to diagnostic, we see that surgery and radiotherapy, particularly radiotherapy, even though these constitute 50% of the indication in terms of treatment, are poorly funded and poorly resourced in relation to research. And the other area that's also is pathology. If we don't have pathology, we don't have personalized medicine. It's as simple as that. So if we don't invest in pathology, both in terms of the workforce, in terms of the technology, we are significantly removing our opportunities in relation to precision oncology. So underinvesting in surgery, radiotherapy, and pathology needs to be reversed. Again, another item that the Secretary General talked about was the importance in patients who are living beyond the cancer diagnosis. We now have 20 million Europeans who are living with and beyond cancer. So one of the things we've highlighted is the need for a specific survivorship research and innovation plan, and also a European Cancer Survivorship Day, and also to avoid financial toxicity. Many cancer survivors who are 5 years or more post their treatment, and we would consider to be essentially cured, cannot get insurance, cannot get mortgages in certain countries in Europe. That is a disgrace. That is just not acceptable in 2023 and as we go into 2024. And one of the things we've been working on European level is the right to be forgotten, where legislation needs to be brought in each European country to actually make it that the patient doesn't have to reveal their previous cancer diagnosis if it's over 5 years, to put an end to this discrimination. I've already touched on COVID, but again, our mantra was don't let COVID become the forgotten sea in the fight against, or cancer become the forgotten sea in the fight against COVID. And as well as that, there is a direct impact as well as indirect impacts of the war in Ukraine. You may not be aware of this, but Ukraine is one of the biggest recruiters to cancer clinical trials in Europe, as is Russia. And so the impact, we've done a number of different analyses just looking at the impact that it's having on cancer clinical trials in Europe and the significant effect that it's actually having. The other thing is we cannot be insular. We cannot just think about Europe on its own. I know Norway has been great in terms of thinking much more broadly, much more internationally, and this is an opportunity. Let's not be insular. Let's look at ways in which we can drive not only research in Europe, but also research particularly in low and middle income countries. We know that deaths from cancer in low and middle income countries to 2040 will rise to 11.2 million. It's going to be the major proponent in relation to disease in low and middle income countries. So we need to work together with our partners. We need to work together with partners in Africa and in South America and show leadership, which I think we haven't shown. If you look at the figures in terms of the amount of spend we've made in relation to LMICs and cancer, it's actually pretty small. And the other thing is to remember, always remember this, health-related research should not be seen as an expense, but an investment. I know that's sometimes difficult, particularly in relation to politics where it lasts over only a short period of time in relation to the cycles of government, but we really need to remember that. These are the 12 recommendations that we've made. I'm not going to go through them in any more detail. Obviously, I'm happy to share these slides with the whole audience. But one thing that is important is that we continue to collect data. And one of the things that's really important to collect data on in Europe is, unfortunately, cancer inequalities. And we've set up a program called the European Cancer Pulse, driven through the European Cancer Organization, where we capture data on inequalities, 120 different data measurements across 34 countries. We published a paper on it in Lancet Oncology there last year. The website is there if you're interested, and you can go in and look at what different countries do. You can compare different diseases in different countries, different modalities, etc., in relation to inequalities. Just dipping into the data, I'm not going to spend time on this, but only 12 of 27 EU 27 countries have an updated national cancer plan. If you look here in relation to diagnoses, if you look in relation to treatment, Norway is doing well in relation to medical personnel. If you compare it with Greece, for example, in relation to numbers of nurses. But you can see there's a lot of differences that we really need to address. Finally, what are we thinking about in relation to variation and how that can affect cancer survival? We know that delays in diagnosis and in treatment can have their impact. We also know the quality of treatment and patient comorbidities can have their impact. But how do we dig down into that in more detail? I'm proud to lead the International Cancer Benchmarking Partnership, which Norway is a member of, and would very much thank you for your support for this initiative. So this is where we've come together on a global scale to look at ways in which we can look at differences in cancer survival and outcomes, but more importantly, identify the factors that are contributing to this and then use them to even up the situation in relation to differences in cancer survival, differences in cancer outcome. As you can see, it goes right across Europe, Australasia, Canada, the UK and Ireland. 21 different jurisdictions in total. And this is just showing you one example. So I could show you many different examples, but this is a recent example where we looked at the importance of cancer policy consistency. So what we looked at was linking consistent cancer policy with outcomes in 7 different cancers. And we developed what we call a policy scorecard. You can see there in the policy scorecard, Norway is doing quite well. It's in the top 4. Unfortunately, Northern Ireland, where I come from, is at the bottom of the league table. The reason for that is because we've only implemented one cancer strategy in the last 20 years. We have a cancer strategy currently sitting, gathering dust on the shelf in the Department of Health for the last 2 years because we haven't had a government in Northern Ireland for the last 2 years. Denmark is at the top of the list at the moment, and if you look at the international cancer benchmarking data from 15 years ago, say, Denmark was down with the UK. So Denmark has essentially invested in cancer, just as Norway has done, particularly in primary care, and looked at ways in doing that. Sometimes it just gets where you say, I can't take this anymore, I've had enough. And that's the situation we face ourselves in the UK, because in the UK, our government and their wiseness have decided to do away with the cancer strategy and develop a major diseases strategy. What a load of bullshit. So we've got fed up with that, and we said, well, if you can't write a cancer strategy, we can. So a number of us came together, again based on data, and came together and developed a cancer strategy underpinned by data, published it in Lancet Oncology, and launched it in the House of Commons in the UK Parliament. This is it, again, the future of cancer care in the UK, time for a radical and sustainable national cancer plan. And we have the blueprint there and the 10 different recommendations. So sometimes you just have to take the thing into your own hands and do something about it if your government isn't able to. So thank you very much for your time. I'm very happy to take questions.